So good afternoon. Welcome to this event at the Graduate Institute on Universal Health Coverage. I'm Ilona Kickbusch. I'm the director of the Global Health Center. And we have been involved in a number of initiatives around universal health coverage, one being the book that we were able to issue last year and which is coming into its own as universal health coverage is being discussed in so many more venues. Of course, with the high-level meeting on universal health coverage in September at the United Nations this year in mind. There have been, and many of you will possibly have been part of that, there have been resolutions at the World Health Assembly also. There is a zero draft for the high-level meeting, which the member states are going to discuss over the next month. So if you have any influence on them, please use that influence. And there's, of course, a fantastic document that's been produced by UHC 2030, the platform for universal health coverage, the 6 asks that we prepared for the multi-stakeholder meeting. So I'd like to welcome you very much to this event. For those of you that have come, we can indicate you will get a gift as you leave, but of course only if you stay till the end. And you will be able to leave with a copy of the book, and we hope that it will be helpful for you and your work. Jeff Sturchio will be chairing this event. Jeff Sturchio from Rabin Martin, with whom we worked on this book. And we were delighted that this also gained the attention of the Director General, that he was willing to give a foreword to the book. What we'll be discussing is perhaps a slightly different perspective from how universal health coverage is perhaps discussed in other fora, because as you can see, our subtitle was Innovation, Equity, and the New Health Economy. And we believe strongly that if we want to move universal health coverage forward, it's not just that simple, as difficult as it is, notion of financing, but that we're talking about a serious economy that makes contributions to individual societies in many different ways. And that we have to understand this economy, an economy that includes both private and public resources within those economic flows. We have to understand local health economies, and just looking at the World Health Assembly, and we were just talking about the local health economy that has a peak like this with all the people coming to the World Health Assembly and every meeting and hotel room being booked. So there is a very local dimension to such a health economy. There is, of course, the national dimensions, and I think Agnes Soucat in particular will highlight that. And there is the global dimension of the global flows, which then relate more to the large global companies that are involved in the health economy. But of course, the health economy is also so much more than maybe just the health companies that we might think of at first instance, and this is something that we hope to highlight during our discussions. So a great welcome from our side. We'll dig deeper into these things. We look forward to your contributions then when we have a conversation after some of the panel statements and discussions. And it's my great pleasure to hand over to Jeffrey Sturchio to moderate and to take us through this early afternoon. Jeff, over to you.
Thanks, Ilona. Let me just add my welcome to Ilona's, and it's really a pleasure to be able to moderate this discussion this afternoon. Ilona's already done a good job of outlining the broad perspective, yes, if Githinji and Fumi will join us, and I'll just introduce them in a moment. Ilona's given you a sense of the broad perspective that the Road to Universal Health Coverage focuses on. It's really to try to take a look at the way in which governments and multilateral organizations can use the many resources and capabilities of the private sector, from private providers all the way to multinational companies operating in a country, to help achieve universal health coverage. Now, I probably don't have to define what universal health coverage is for this audience, since it's been on everybody's mind this week. But it's simply stated. It's the idea that everyone should have access to an essential package of quality health services without fear of financial hardship. Now, that's easily stated, but it's proving to be much more complex to achieve, and that's really what we want to talk about. The task of turning that vision into reality poses significant challenges for countries at all stages of economic development. As my accent suggests, I'm from the United States, and I'd be the last to argue that the United States has figured out universal health coverage. But we have vastly more resources than a country like, say, Niger, which will also be grappling with the same set of issues over the next decade. So we want to take this perspective of looking at the private sector's role, both now and in the future, to help discuss ways in which the new health economy can help countries to achieve universal health coverage. I'll just say another word about this, that the other thing that is going to pose a challenge is that the WHO estimates that half the world's population still lacks access to essential health services. That's a very large number. It's billions of people with a B. And that number, which is staggering on one level, masks inequities that exist between and within countries. So we have gaps between rich and poor, men and women, young and old, people of different ethnic backgrounds. As Dr. Tedros has often observed, we want to leave no one behind. So the task of turning that vision into reality is what we want to talk about here. And we'll explore the different ways in which the private sector is helping and can continue to help to address those questions. What conditions are required for countries to translate the successful experiences and policy promises that they've had into practical results for improved population health, and what kinds of success factors are there for private sector engagement in universal health coverage, and a number of related issues. As Tedros has also observed, all roads lead to universal health coverage. So whatever perspectives you have a contribution to make to this set of issues. And at the end of our discussion, we'll have time for all of you to contribute and ask questions. So we'll look forward to that. It's really a pleasure to welcome our other panelists. You have a brochure that has more information about their backgrounds and interests, so I won't take time. We could take the entire hour to talk about the many activities and accomplishments of each of our panelists. To my left is Dr. Githinji Gitahi, who's the Group CEO and Director General of Amref Health Africa, and also co-chair with Ilona of the UHC 2030 initiative to help achieve UHC by that date. And then Ilona is next, who's introduced herself. To Ilona's left is Agnes Soucat, who's the director of the Health Systems Governance and Financing Department at WHO in Geneva. Before that, she was an economist and global leader of service delivery at the World Bank. And to her left is Fumi Griego, who's the deputy director and chief operating officer of the International Federation of Pharmaceutical Manufacturers and Associations, based here in Geneva. So let's get started then with a question to Githinji. If you could, I thought it would be a good place to start is if you could talk to us about the UHC 2030 asks, which really provide a framework for the rest of our discussion.
Thank you, Jeff. I think I can speak from here.
Sure.
Okay, good. Well, I think the first point to say is that I got a copy of this book. It's a fantastic book, looking at the roadmap to universal health coverage. But as I said earlier to Jeff in a meeting we had, that road is winding, long, and full of potholes, and therefore is not a straightforward road. And part of the conversations in that book and about the health economy have to consider the context within which those who are left behind live, when I look at the figures at $6.5 trillion dollars, and part of that economy, close to 50% of that is actually the US when you add it together. 300 million people times close to $10,000 per capita. When you actually add it together, the rest of the world is sharing the other half, and the US is taking all of it. So these are contexts that we put into place when we're looking at if we are going to achieve UHC, and UHC is all about those left behind, it's all about equity, then how do you position these conversations? So the first thing I would like to say is that, most importantly, UHC is first and foremost a political choice. And therefore, the conversations this year around UHC are about political support, political momentum for UHC. But at the end of the day, we'll then have to go down to the countries and say, so what next? What do we do after this political declaration? So this year in September, we have the heads of government assembling and discussing what is it that's really important for us when we go back home to consider about UHC. So the UHC 2030, which is a multi-stakeholder platform, which brings in together civil society, academia, member states, private sector, brings all these together, has been doing consultations, and those consultations have been far-reaching across all the continents, online, face-to-face, and these consultations were geared towards driving to a set of requests that should feature in the high-level declaration that is going to be considered and approved in September, and which Ilona has spoken to, that already there's a zero draft, which is available publicly. So when we did our consultations, there were 6 things that came up that are really critical for us to look at as we move towards an equitable universal health coverage that looks at, first and foremost, those who are left behind. And the first thing was to drive political leadership beyond health. That actually UHC is not an issue of health only. It's an issue of rights as a social contract. It's an issue of all the other industries and sectors playing a role, including governance, political leadership beyond health. So that was critical. The second one that we picked up is within this political leadership beyond health, looking at those who are left behind so that no one is left behind. And this speaks about equity. It speaks about disaggregating some of these statistics in the global economy and saying, when you talk about 6.5 trillion, where is that 6.5 trillion? It's $10,000 in the US per capita. I'm exaggerating it a little, maybe it's 9,000 plus, but just for argument's sake. But when you move down to Malawi, it could be $17 per capita. So how do you actually balance and look at those who are left behind? I think I did some quick statistics for a meeting I was moderating yesterday. And I tried to put this in perspective specifically for the African continent, to say that the African continent is 1% of the global GDP, 1%. And it's going to take 70 years for it to even reach 10% of the global GDP, even if it was to grow at 5%. So when you look at that and you look at the population growth and you divide that, and then you say, let's assume the African governments were going to collect tax at a really high tax efficiency, despite the challenge of informality of their economies. And they're probably going to achieve the tax efficiency of OECD countries and give them a 30% tax efficiency from their current 13%. So really a dream, but let's take that constant, as the economists say. Then you assume that after collecting that tax at such a high efficiency level, they're then going to allocate what we require them to allocate, which is 15% of GDP of their expenditure, their budget expenditure to health. You still end up with $40 per capita per person. So how do we look at those at the $40 and make sure that those people in fragile states, in urban slums, are still addressed with equitable UHC? So leaving no one behind is really critical, and disaggregating data so that we see exactly where the focus should be is important. Now, the next thing is about what we are talking about at the role of private sector, that health does not succeed in a free market. It fails in free market. In most of the studies you see. So how do you make sure that there is regulation and legislation that allows equity to be at the center? So that's the third ask, that regulation and legislation, with government taking its role as the duty bearer. Somebody said in a meeting we had in Kigali in March that in a bus, the only position that never changes is the driver's position. Anyone else can change their seat. but the driver can never change their seat. And the government must not change its seat. The government must sit on the driver's seat and lead the conversation around equitable UHC. So regulate and legislate so that you have an equitable health system. Then that allows private sector to participate in a coherent and responsive manner. The fourth ask is about quality, that within all this, you must think about quality services, starting at primary healthcare. And the next ask was about not only getting more money from this health economy, but spending it better. If Africa is going to spend $40 per capita, even at maximum tax efficiency and maximum allocation, then it talks to you that it's not about money. It's actually about optimization, efficiency, and what is it that private sector can assist to create efficiency, scale, and low costs so that we can achieve UHC. And finally, it's about moving together with private sector and all other players so that we can achieve this equitable UHC. So that kind of summarizes the 6 asks, but around that is that they must be placed in the medium of gender equity and women and girls' rights, because really when you look at those left behind, it is this constituency. So that kind of summarizes, but I'm sure I can talk a little more about the other things as we move overhead about what do we need to do to walk the talk when we get back to the countries.
Thank you. Well, thanks very much. Let me just ask you a follow-up question, Githinji, on from your perspective as the leader of a very large civil society organization that both advocates for and delivers healthcare in Africa. How do you see the way in which NGOs like yours engage with other players or other actors in the health ecosystem to help achieve universal health coverage?
The way I see, I tend to look at civil society as the third sector. So you have the public sector, the private sector, and then you have the third sector. And that third sector is literally what I call a trust broker. What happens between the first sector and the second sector is people put governments in power, but government's role is to regulate and to make sure things are going well. It's government, it's to govern. So there's a kind of sort of a relationship between the people and the government that is also a suspicious relationship. And when you come to this other side of the private sector is there to give a return on investment for their shareholders. And therefore, there is, despite the fact that the people draw services and pay for them from the private sector, there is, again, the suspicion that, are you taking too much from me? Because, the pricing models are not always open, and how much margin. I worked with a pharmaceutical company that was selling paracetamol, and the paracetamol was at a 70% gross margin. So as you work, where do you draw the line? So there's suspicion. How much are you charging me that you shouldn't be? So that suspicion is what the third sector comes to broker. That actually, when the private sector is coming to work, the government also has a distance between itself and the private sector. So we tend to bridge that gap of trust. So because we are trusted by government to a large extent, because we are seen not to be, for profit, we then bridge that gap between the government and the private sector. So we bring private sector. For example, I'll give you an example of what we are doing in Kenya with one particular organization called Philips. Now with Philips, we're going to say, let's test a model to see whether private sector can really play a role in the primary healthcare space. Now, if Philips goes to the local government of Makueni, the county we are working in, and says, we want to run your public facilities and see whether they can be efficient, that will not happen. They'll be like, we can't trust you to run them because are you going to charge people more? And then, but we in the middle can come in and say, let us work with Philips and also bring this side, the government, and say, we will broker the trust, so you trust us, but we'll form this special purpose vehicle between the three of us, and then see whether private sector can play a role in public sector. So this is the role we play. We are trust brokers. And number one. Number two is that we assist, and also this is trust brokerage, we assist private sector to access the bottom of the pyramid, or the markets that actually need access. So when we talk with, when we work with organizations that have low-priced commodities, how to distribute them to the bottom of the pyramid are things that we also kind of bridge. So that's how we work in a broader scale.
Thanks. Well, we'll come back to those issues in a few minutes, but that was helpful. And yes, if I could turn to you next. One of the issues that Githinji talked about in terms of the 6 asks from UHC 2030 was financing of universal health coverage. And I'm sure that that's something that you and your colleagues at WHO are thinking carefully about and working hard on. So maybe you could just lay out the way that you're looking at this issue and how national governments and other potential sources of financing can fit into that picture.
Thanks. Somehow I'm not surprised you're asking me a question on financing. I actually want to sort of build on what Githinji mentioned about the health economy and what we are here to talk is what I think not everybody still perceives is the fact that the health economy is very rapidly growing. So what we've been seeing between 2000 and 2015 is a systematic, fast growth of the health sector that is much faster than the overall economy. So if you look at the sort of global picture, the rate of growth of the economy between 2000 and 2015 was about 2.8%, sorry. The rate of economic growth was about 2.8%. But the health economy, the health sector, health services have grown by 4% annually, so much faster than the overall economy. And more interestingly for us is that if you look at actually low and middle income countries, then you find that this number is even higher. So while the economy grew at about 4% in those countries, the health economy grew at 6%. So we're living a phase where we are moving away from the problem is spending more to how we're going to transform what is now an incredible growth of the markets for health services into actually performance of these expenditures in terms of delivering social goods. And so if we see what is spent in the world today, it's 10% of GDP. And Githinji clearly pointed towards something very interesting, is actually a very large proportion of that, around 40%, is actually the US. So we have a health economy which we know is actually driven by health spending. Mm-hmm. Right? And it matters because the health spending drives, the spending in the US drives the global economy on health. It has consequences because it drives the market. But it's about 7.5 trillion, so 7,500 billion spent on health, 10% of GDP of the world. But interestingly, actually 5.6%, so a large percentage, around 60%, is actually public spending. So it's driven, I mean, it grows very fast, but it grows very fast both on the private side and on the public side. And even when you mention your country, which is the largest spender and drives the economy, in fact, most of the spending in the US is public, right? It's because of Medicaid, Medicare, and it's because of the subsidy to the health insurance, particularly with the Affordable Health Care Act. So there is a market, but there is also a very strong role and a very strong involvement, a very strong stake of the public sector. So in many ways, so what it means is between 2000 and 2016, the public spending on health in the developing world has multiplied by a factor 5. And what we see is health expenditures have grown in every country, often by a large percentage of GDP. And this is where there is an issue, except in low-income countries. And that comes to a surprise to many of us, because we've heard a lot of, good things about global health and global health spending and how ODA has increased for health. It has actually been multiplied by 5 also. Moving to a little bit more than 20 billion per year by 2016. And then say, so what happened? And in fact, the issue in those countries is that external funding has displaced domestic funding. So it's what economists call fungibility. And then there is this really issue about bringing external funding into systems that are not ready to absorb this funding, because there are significant constraints that block the scaling up. So where does it take us? You know, about your question, what is it that we should do? I think when we look at the trends, and you know now that actually generally the economic prospects in the world are very positive, and I will just take one exception to it, I'll come back to it, is what we see is very, very good prospects in terms of more money for health. There will be more money for health because the markets are driving it, because there is the new health economy in which, in fact, we see that what is called the fourth industrial revolution, in which you see less and less job in manufacturing because of automation, because of digitalization, because of artificial intelligence. Actually, the health sector continues to be a sector in which the number of jobs continues to increase, again, at a faster rate than the rest of the sectors. So you have context like whether you look in the United States or in India, where the fastest growing sector in terms of job creation is the health sector. In the US, it can be, when you look regularly in different job creation reports, you would see 15 out of the 20 fastest professions are actually in the health sector. Right? So this is a transformation of the economy in which it looks like the health sector is going to be a growing sector of the economy of tomorrow. And that has a lot of consequences which we don't have completely figured out about how far can we go in terms of how much of the economy can go to the health sector. And that's a question we discussed in the Commission on Health Employment and Economic Growth in 2017, and we discussed it with Joe Stiglitz, Professor Joe Stiglitz, who's Nobel Prize in Economy. And we asked him, is there an upper boundary on the spending on health, when it's like the US is at 19% of GDP? Is there a point at which you would say, this has to stop? And it's like, well, it doesn't see really any problem to go to maybe 25% or 30% of GDP. The problem is not that. The problem is whether these expenditures are productive for the society. Is because it says if these expenditures goes into rent seeking for the insurance industry with 20% overheads, or if it goes into non-productive expenditures that just provide windfalls to the pharmaceutical industry, then probably it's not a good thing. But at the same time, if it goes into human capital investment, reducing inequities, improving social capital, then we have evidence. We have some solid evidence from Germany, but we also have new work that is produced on the multiplier effect of investment in the health sector. And then you see investment in the health sector actually good for the economy. Not only because of health, that we already knew, but because health services are actually, when they are productive, they are improving the productivity generally of the other sectors. So to conclude on your question, so what does it mean? It means that I would say there are sort of three main messages. For the high-income countries, it means you need a major transformation of the way health is funded, moving from what we do today, which is funding high-cost technology that are very little productive in the last months of life, and moving to primary healthcare model, prevention, promotion, and actually there's a commitment of those countries to move to that, but it's not easy because the whole system is geared toward those last months of life. For the middle-income countries, the prospects are really excellent. When you see the 7% economic growth in India, Asia growing, what you see is that actually fiscal space is expanding. The question there is how you're going to transform the private spending into public spending. So it's how you do taxation, progressive taxation, pro-health taxation, the taxes on tobacco, alcohol, sugar, and how you transform that into productive public spending. And in those emerging economies, middle-income economies, the question is how you get the money to the poor, how you get the money to primary health care. And then you still have the vexing problem of the low-income countries, and in many ways that goes to the problem of Africa. Because there actually the economic growth is of concern right now. Is you actually have per capita negative economic growth right now in Africa because you have such a high population growth. you have an incredibly rapid increase of the population. The Africa population is going to double. You mentioned it's 1% of GDP, yes, but it's expected that by 2050, it's going to be 20% of the world population. Africa is going to be 20% of the world population. And yet, we don't have good economic growth as a per capita basis. And the past experience was actually a decrease in health expenditures. So there, I would say, it sort of really calls for what we hear more and more. It calls really for thinking differently. And the whole paradigm of development cooperation, the whole paradigm of what do we do to foster better investments in health? How do we do to invest in health system? How do we get a health workforce? How do we get health infrastructure? I think when we look today at the debate, is how is it that clinics don't have water and electricity in low-income countries after all these years? How is it that we don't have the most basic health workers? We know that Ethiopia did it in 3 years. To train 30,000 health workers. Why is it not happening elsewhere? I think it's a kind of question that are really a bit vexing that we need to tackle.
Well, thanks, Agnes, and you're right. Those are vexing questions, and we'll tackle them in the next part of the discussion. So I'm not sure we'll solve them all, and it's good to have some data. So we can always count on the economist on the panel to give us some data. But that was interesting, and I'd like to ask Ilona to just drill down a little deeper on this notion of a health economy, because, as Githinji and Agnes both observed, even though the health economy is growing, even though there is a lot of money invested around the world in health, it's not getting to the people who need it the most. That was the other question you made about productive expenditure. But there's still more money that would be available if we thought differently about healthcare financing. And in a sense, it's to the point where you started, Githinji. You said what we need for UHC is a political commitment beyond health. I think we also need to think about the health economy beyond the health sector. So, Ilona, would you like to just comment on those questions, which I should say are the subject of Ilona's essay in The Road to Universal Health Coverage?
Yeah, so I'll only make a couple of points. First of all, really taking up what you indicated, Jeff, that we are too narrow in that we always look at what in our book we call the core health sector. And here, we have all kinds of discussions about investment, frequently using the word investment quite differently from the way economists use the word investment. We talk about expenditures, and we forget that these expenditures can have incredibly positive impacts if you look outside of the health sector. So we're not looking at the dynamics. We get stuck in thinking within our sector, and Agnes has already highlighted some of these larger effects. The other is, of course, that we have to move beyond this core health sector to look at, what we might call the extended health sector. And that's important because this is organized and regulated so differently in different countries. What is social work in one country is part of the work of the community health nurse in another country. What is elderly care, totally separate and in another ministry in one country, is part of the health sector responsibility in yet another. And so we also haven't mapped those interfaces properly, and we don't understand their dynamics. Then Agnes has already related to what we called, so those are services and products in the widest sense, and they include, the pharmaceutical products and everything you need basically to run a service. But then, you have those resources that feed into this economy and without which this economy could not work. So you have really the capital investment that is needed. And in order to build a hospital, a string of primary healthcare centers, in order to develop research, etc., you need capital investment. And again, in terms of public and private, the question is who makes this investment? And also, where does the investment come from? Is it then, a foreign investment firm or even an equity investor with, very specific profit interests? Or does it come, out in quotes of the national economy? Is it perhaps even investment of the government itself? And we often underestimate, the investments in physical infrastructure and supply chain. The other, of course, then moving beyond to the health sector is the investment in training the workforce. And already Agnes has alluded to, who pays if you want to have a contingent of 300,000 community health workers overnight, basically, and who is willing to invest in that. And the tragedy is that many of the foreign investment, if we look at the donor money, is rarely willing to pay for this. They move down usually the product side. We'll pay for vaccines, we'll pay for AIDS medicines, etc. But we don't have a global effort to really invest in such a health workforce. And there, of course, the impact of such a workforce, first of all, it's jobs for women. It's extraordinary what that means. And, if we look at some of the results, that what do women spend their money on? They, for example, spend it on the education of their children. So, you also have generational effects that come through the health economy that are very critical. And then you have cross-border effects, because sadly, to some extent, a range of that workforce leaves the country and works elsewhere. But if you look at some of the figures of remittances coming back to countries, which is so much higher than any foreign aid, and sometimes even the tax base, you will get a financial flow that is absolutely essential for, I would say, the economic survival of some low-income economies. So, which is why, of course, also some countries are actually consciously producing health workers and sending them abroad in order to get that money. So that's an additional flow. And then, perhaps the last flow, which relates very much to the 4.0, Agnes has already said how that, is actually expanding the health and care service workforce. But of course, now one of the major economic investment factors in health is technology and digital technology in the widest sense. So who is driving health investment of a totally new type? The Googles, the Amazons, a whole range of startups, etc., etc. They're really changing the economic face of the health economy. And therefore, what we plead for is really to look at that complexity, to map it clearly, and therefore to have a better understanding for what Githinji highlighted, what part of it needs to be regulated, what part of it needs to be redistributive so that it reaches the poor. Is the system with which to do the financing a social insurance system or a tax-based system? What is more appropriate in what kind of country? But in the end, to always, and you will see that in our article, to say, how does that stabilize or even drive economic growth? What is the economic outcomes linked to the health productivity and the health outcomes? Because it's no use if you have a growing health economy and you don't get more health for it. But also, how does it drive and stabilize employment and growth? And particularly that employment factor is an absolutely central and critical one, and we just do not discuss it enough, and it is a gendered one, which is why it's so critical for everybody. And this impact that you have said, Jeff, on social capital, on human capital, is just absolutely extraordinary. We have to retell the narrative of what a health economy means and what universal health coverage within what we consider to be a highly regulated market, actually, to ensure quality, to ensure equity, etc., what that implies, and what that implies at this point in time where technology is totally changing how we organize health.
Well, thanks, Ilona. I think that really shows us, at the outset I said that it's easy to say we want universal health coverage by 2030. It's very complicated to get there. I think between what Agnes and Ilona were just saying about looking at the health economy demonstrates just how complex that economy is as it operates. The other thing that I think is important is to just remember the terms of the numbers. From Agnes, she was saying that it's, I think you said $7.5 trillion now is being invested. And there are other estimates that it's as high as $10 trillion right now. Contrast that with the 5-year request from Tedros for the WHO budget, which was, what was it, 15 billion? Not quite $15 billion. So remember, a billion is 1/1000th of a trillion. And I think in a way, just to summarize in a very simplistic way, what Ilona was just talking about is, if we could find a way to reallocate some of the $10 trillion flowing through the health economy to provide greater support to WHO and the other institutions that are working with countries to achieve universal health coverage, the problem solution would look a lot easier than it does right now.
Actually, the budget is 2.5 billion per year.
Yeah. So
if you compare to the 7.5 or 10 trillion, it's really a drop in the ocean, the budget of WHO.
Yeah. And then that gets into all kinds of complicated questions about budget envelopes and fiscal space and all that. But before I get to a question about that, I wanted to turn to Fumi and so we've heard about the complexities of the health economy. We've heard about from Githinji about some of the ways in which civil society is working with government and the private sector to move along this long and winding road to universal health coverage. So, Fumi, you have experience that's interesting in two ways. I mean, you represent a group of companies and associations which provide a tremendous contribution to the inputs into the health economy through the drugs and vaccines and other contributions they make. But at the same time, those companies are economic actors in this health economy. So just talk a little bit about how you look at these questions and what role does the private sector, in particular the pharmaceutical sector, have in the road to universal health coverage?
Well, thank you very much. I could say a lot about this, but I want to focus on something that actually comes from the asks. Because the ask which the private sector is contributing to, and of course IFPMA is a member of the private sector constituency and very much endorses these principles. Ask number 5 is not just invest more, it's invest more and invest better. So I think what that comes down to is a common theme I've heard in some of the conversations this week, which is, we talk about private-public partnerships, but that's too sort of, it's not dichotomous in that way. And it's really about what are partnerships for shared outcomes. And so I really emphasize the outcomes part about in terms of achieving investing better, because we really need to put health outcomes, patients at the center, and if we align our incentives around that outcome that we want to achieve together, then I think a lot of the issues that we're dancing around goes away. In some sense, if we can align about what are the quality standards that we want to reach, what are the things that we want to achieve together, then we should be in some ways agnostic about private, public, small, large, or not-for-profit or for-profit. I think if we put that kind of more agnostic, especially at a global level, sort of perspective on it, then I think it's really up to some of the more localized discussions on, what do we have to work with? How do we incrementally improve? How do we systematically improve? But at least then it's sort of grounded in the realities of national and local context. But I think what's critically important across all of this is really to define what is it that we're trying to achieve together and having a framework for engaging, but also for measuring outcomes and output to make sure that all of the actors around are held accountable to that goal that we want to achieve together. So I think there's a lot of complexity in, what does private sector mean? It really varies from country to country. I've worked on policy in China and in the US. in India as well. The actors and the affiliations, if you will, of public and private is very different from country to country. So it's really hard to define it at the global level. And I come from an environmental background, so I always think, think globally, but act locally, and really figuring out who do you need around the table who can help achieve the health objective that we need. And there is, unfortunately, a lot of inefficiency and waste in every system. I come from the United States, as you can probably tell from my accent. There's a lot of great spending on good outcomes, but it's not always efficiently and effectively spent that way. So I think it's really important to set the right standards in terms of qualities and outcomes. And from a private sector perspective, one of the key things that we're good at is aligning around incentives, responding to incentives. So if the system at the right level, most likely locally, sets the right incentives for how everyone is going to achieve towards that common goal, then I think we also invest better in addition to trying to invest more into strengthening health systems. And I want to touch on something Ilona said, because, and when you get your books, if you don't have it yet, please take a look at the chapter on healthy women, healthy economies. That's a topic near and dear to my heart. And in full disclosure, I used to work for Merck, who co-authored that chapter. But it's this idea that you can achieve social equality goals, such as women's participation in the economy and equitable access to health outcomes for women, together with so you have both the health and the economic development piece. And also, if you encourage health participation professionally by women in the economy, you also improve health as well. So there is a sort of a virtuous cycle and a positive relationship that we can't forget in all of this. And so it's really thinking beyond just health and health impact, but the broader productivity and impact to the broader economy.
Yeah, no, thanks. That's really important. Ilona, you wanted to...
Yeah, just one point on the women's thing. There is, of course, a formal and there's an informal economy. And if you look at the informal health economy, I mean, there's lots of, providers that some of us might not want to go to, et cetera. That's a different discussion. But, the amount of care work in the informal economy by women is also something like housework in general that is not usually counted. So if you were to combine the formal health economy and the informal health economy and the value of that globally, you would probably be at least at 20 trillion. So, look at that, and we have to take that into consideration, because in our societies and our economies, we will not be able, to move all of that into professionally paid care. And therefore, your third sector point, also with NGOs providing a lot of services on the ground, often in a voluntary manner. So always when you talk economy, there's a formal and an informal economy, and the value of that informal economy in terms of money, but in terms of value is, what it produces and its outcomes is absolutely essential, and we must not forget that, particularly in health and care.
Great. That's another important point. I mean, in many ways, the informal economy of the contributions of women is just ignored in many of these analyses. So I'm glad that you both brought that up. So before we open the floor, I just had two questions that I wanted to pose to the panel, and we'll take a few more minutes to do that. One is, Fumi mentioned, the mantra of the environmental movement was think locally, act locally. And I was at a meeting last night on social accountability, one of the many side events that we've all been going to this week. And after an interesting discussion about social accountability mechanisms and how they can help hold governments to account, all that was really important. Someone from Ghana, a young person from Ghana, stood up and said that, there have been X reports over the last few years on universal health coverage and all kinds of plans at the global level for how we're going to achieve this. But the question I have for the panelists is, what do we do at the local level to actually implement these plans, and where do we find the kind of tools that we need to really make these aspirations a reality? So I wondered if you would just, each of you, if you have comments on that. We might start with Githinji, because that's the work that your organization does. But how are we going to take the resources that are flowing through this health economy and apply them in a way that will actually lead to, not only will we have more money for health, but we want more health for the money?
Thank you, and I've had this question actually from many people, so the young contributor was right, that actually the challenge is coming from the streets of Geneva and New York. When you get back home, what actually happens? Because action has to happen back home. So we are not talking a lot about country-led plans. And in our conversations as UHC 2030, we are looking at, so what do we do the next day? When we wake up in the morning, the political declaration is done, then what? So UHC 2030 is starting to think about that, because all our members are member states, and back in their country, they want to know what the people expect. But so what next? Now there are two major conversations. I think the first conversation is how to put people at the center. Governments report to the people. Everyone has a boss. And governments, the boss of governments is the people. But I don't think that power has been exercised enough to understand that governments report to the people, and therefore how do the people exercise that power, that reporting power? And the only way that people can do that is, one, by empowering grassroots organizations, because even the organization I run, which is Amref, there is a way, even if we are indigenous to Africa, we grew out of Africa and work in all these countries in Africa, up to 35 of them, we are still seen as an international NGO. So there is only so much we can do to demand action from government. We can work with them across the table, we can advise. But at the end of the day, the grassroots organization that we work with is the one that can stand up to its member of parliament and make demands. But for them to do that, they need data, they need evidence, they need what is it that we are demanding. So the question of data and evidence is really important. And today we had a very important session on a primary healthcare performance initiative, which is really starting to ask questions about, so if we have to, and this is my second important point, that we have to focus UHC on primary healthcare. And primary healthcare is about public health and primary care near where people live and work. Now you have to measure how much money is going there. You have to let the people know how much money needs to go to the primary healthcare so they can demand with their local assemblies and the national governments. So we have to put frameworks for providing data and evidence to the people and then empowering them and capacitating them to participate. And we are seeing this in many governments like Tunisia, Iran, Thailand, with what they're calling the National People's Assembly, coming up and starting to develop grassroots energy to demand from government. So that's what we need to move to after the declaration.
Terrific. Any others?
Actually, IFPMA benefits from being not only an association of member companies who are multinational, but national associations as well. And so I think what's critically important is being engaged at the policy process at the national level. And perhaps, global platforms like UHC 2030 can help facilitate bringing health forums together, because what I think what a lot of the energy behind the high-level meeting that we want to have in September is really bringing together the entire wider health sector to really make the case for investing more and better towards health. And so the more we can get all of our aligned interests together, working together, rather than fighting over the scraps, if you will, that's handed to us. So I think there's a lot of, to use Githinji's word, power in coming together. And so I think from how do we operationalize this is if we can perhaps put aside some of our disagreements of the past and align around our common goal at the national level, I think we can really facilitate some change.
Great.
Maybe what I'd like to add to that is modern welfare states are something very recent, right? It's not more than 150 years, and for the developing world, it's often no more than 40, 50 years. So we're still learning about what works and doesn't work in modern state building and performance of modern states. But what we certainly know is that if we agree, and I think there is growing consensus that health services generally are better funded through a collective mechanism because they are fundamental market failures. The market failure of the insurance market, the fact that there's a lot of public goods in healthcare, and the equity argument for the welfare state. So most countries today in the world have agreed that most of the financing of healthcare goes through some kind of collective mechanism. So collective mechanism means that we need collective action. And we know that to foster collective action, we need a couple of ingredients. One of them is national conversations. It's if the state, if the country is the unit of conversation, then we need national conversation. We need people's platforms, citizens' platforms that bring together all the stakeholders and that bring together groups that may actually have a very different view of what the public purse should buy. But they need to find a consensus. And they need to have some kind of democratic discussion there. And that always ends up somewhere into a parliament that has to make tough decisions about what is going to be funded or not. So one part is really that conversation. And in WHO now, we're really, really very much behind the view that every country needs to really have this kind of mechanism, whether it is called a societal dialogue in some countries, a state general of health in my country, in France, which is a very well-established process, or National Health Assembly in Thailand, that you need a platform in which this conversation actually takes place. And you can, and people who have no voice, if we're talking about leaving no one behind agenda, need to be able to express their voice. And the second thing is yes, you need a planning process once a decision has been made about the direction of the use of the public purse, and it requires a government that is able to transfer funding to providers. It's about provider payments. It's about providing incentives and shaping the market. So do actually public money gives instructions to the market about what to do, and that it's associated to a legal framework with regulation. And again, that is part of an institution building agenda. It's a modern state building agenda. And I think we increasingly, again, moving from a question of, I mean, is UHC desirable? I think there's now the consensus, it's adopted, it's part of the SDGs. Is it feasible? Yes, technically we know it's feasible, it's financially feasible, but the question is how do we build institutions? And that, yes, we still have a lot to learn, and there's a lot of trial and error thing.
Well, I think I like the fact that you've pointed to how much there is that we still have to learn about how health systems operate and how we can help them to operate more effectively. You reminded me of a comment that Nigel Crisp made in a book he published a couple of years ago. I think the title was "The World Turned Upside Down," which was on the relationship between health systems in developed countries and health systems in lower and middle income countries. And he was talking about what can we learn from the experience of lower and middle income countries that informs the work that goes on in developed countries and vice versa. And he said, and this is what stuck with me, we all have something to teach and we all have something to learn. And I also liked, Agnes, the way that you came back to Fumi's point about incentives, because there's often a tension, and Githinji started with this point in his remarks about how Amref and other CSOs serve as trust brokers, that there's often a tension between the public sector, which is trying to be a steward for the entire health system in a country, and the private sector, where people often feel that the private sector has motives that are misaligned with providing for improved health and improved health care. But often the private sector responds to incentives. So if those incentives are structured in the right way, you can make sure that the resources that the public sector is using to procure health products and services are used in a way that is both equitable and accountable. So, and that's one of the other points that, as Ilona has mentioned, we've tried to explore in the book. There are many other issues I'd love to bring up with the panel, but we want you to have a chance to contribute as well. So why don't I open the floor, and just if you have a question or comment, just raise your hand, and please introduce yourself when you get up so we know who's talking, and try to be succinct. Okay, where should we start?
There's people over here.
Oh, good. All right, well, let's start right in the front. But do we have a microphone?
Sorry, it's upset.
Oh, all right, well, you have the microphone, so you can start. Go ahead.
I've got the power of the mic. Yeah. So hi, everyone. I don't know if this is working. My name's Ben. I'm a junior doctor in the NHS in the UK. And the thing that concerns me on this topic is around equity. And we are seeing inequity increasing all over the world. There was a UN rapporteur report on the impact of austerity policies on human rights in the UK. And in 2 years' time, 40% of children in the UK are going to be living in poverty. We're living in a world where 8 men own the same as half of the world's population. And if we use a kind of a corrected poverty line, which says that $7.40 is enough for basic nutrition and for everyone to achieve an average life expectancy across the world, and 4.2 billion people are living in poverty. And going back to universal health coverage, this started in 1978 with the Alma Ata Declaration, which was an incredibly powerful declaration that called for health based on human rights and equity and social justice, and it called for a new international economic order. And my concern today is that we're trying to fix the problems that have developed over the last 40 years with the same system that has caused all of those problems and has caused inequity to be increasing and people's human right to health to be infringed. And just to lastly end on, there's been a lot of conversation this lunchtime about growth, and that is something that hugely concerns me. In Committee A this afternoon, they're talking about climate breakdown, and we have 11 years left to avoid catastrophic warming of the planet. Economic growth, as it currently is, with business as usual, is not compatible with our planet and with achieving social justice and achieving the human right to health. And so my question, going back to the panel, would be, how do you equate those two? Do you really see a process for the private sector who are avoiding taxation and contributing to a huge amount of the problems that currently exist, being part of that solution? And I would say that call for strong public health systems that is based on a human right to health that is being ignored all over the world. Thank you.
Well, thanks. We'll let the panel ruminate on that comment and question for a moment, and then come back to it. Let's just take a couple more. Right down here. And
thank you. I'm Shariha Khalid Erickson. I'm from Mission & Co, private sector constituent member of the UHC 2030. I'm just really interested in the conversation around the future of health services. And I do agree with the gentleman there. I used to work in the NHS too, by the way, and it hasn't changed much since I left 12 years ago. I think we are largely thinking in the present and the past. And, you know, if you look at the financial industry and how quickly that got disrupted in terms of how people are sending money to each other through their mobile phones, through, you know, fintech solutions, that's going to happen very soon in the healthcare space. But we're still thinking about how healthcare is or has been delivered. I think we just need to be ready as a community to face what is coming next. That's number one. But also to accept that the people will find a way and businesses will find a way to address gaps that exist. And the key question here is, how do we prepare for that? So that's really my question back to the panel, you know, because we have all these aspirations for partnerships with multi-stakeholders, but we're still trying to address a challenge or the gaps and a system that exists and operates as it is now.
Okay, that's another thought-provoking question. Do we, here, we'll take this third one in here and then go to the back, and then we'll have the panel respond. Go ahead.
Great, thank you very much. My name is Lisa Morgan. I'm from the International Labour Organization. Thank you for a wonderful discussion. I have a question which perhaps all of you on the panel can think about, but maybe it's more to Ilona and Agnes. You mentioned in your talk that what you need spent on healthcare per year is around 7.5, what did you say, 7.5 trillion, is that right? And what I'm thinking about here outside of this is the wellness economy. So you have the health economy, then you have the wellness economy, and perhaps this is part of the sort of indirect universe. I don't know if that is included in the 7.5 million, but from what I've read, the wellness economy spends about 4.2 trillion per year. And this mostly is spent in the private sector. So when we're talking about private sector spending on healthcare, I just wonder, how impactful is this wellness economy? Do you have an opinion on, whether, so just so that we're all on the same page, wellness is all the industries that enable consumers to incorporate wellness activities into their daily lives. So we're talking a lot about promotive and lifestyle-related things, diets, exercise, that kind of thing. So how impactful is this on UHC? Is it something that we should really be focusing on, sort of the preventative side of things? Thank you.
Okay, thanks. And then our last question.
Okay, my name is Christophe de Coster from the Institute of Tropical Medicine, and I actually have a question for Agnes Soucat. Why I largely agree with the gentleman who asked the first question, I was kind of wondering about sub-Saharan Africa in particular and the low-income countries there, because you painted a rather dark picture there. Is that true for most of them, or would you differentiate within Africa? Would you say that in some parts of Africa, UHC definitely has a better future than in others? And what would you suggest to make progress in all? I understand that in the current environment, the global fund for UHC is out of the question, but how would you then consider to make progress even in the, more difficult parts of Africa?
Thank you. So let's turn back to the panel then. So we have a couple of big questions about, will business as usual get us where we want to go? And is that just going to substantiate or perpetuate the kind of injustice that we see in the disparities in healthcare around the world? The second question was, in a sense, a different way of looking at that. How can we prepare for the future of healthcare? Because we know that there are technologies and other models that are that could disrupt the way we do things, that might actually end up getting us more health for the money and a more equitable distribution of health. A specific question about the wellness economy and how that relates to all of this. I'm reminded that it's often observed that what we have is a sick care system, not a health care system. So that relates to that. And then finally, is Africa ever going to achieve universal health coverage? Are there some bright spots? And what are the factors that differentiate those countries that are on the right path versus those that still have a lot of work to go? I should say there isn't one right path. Another thing that Tedros observed in the foreword to our book is that every country will have its own unique path to universal health coverage. But those are the four questions. Who would like to start? Ilona?
Well, I'll just start with some elements. Yes, there is an enormous wellness economy. Point two, its outcomes are not really measured. It's very much, as you said, a private market. But it's interesting, Germany has actually tried to measure the different dimensions of the health economy. And there in the Ministry of the Economy, they speak of the first and the second healthcare market. So a lot of that wellness economy is sort of that second market that contributes. And you're quite right, one has to look at it. It's a very profitable market. And we've seen companies from the first healthcare market actually move into the second healthcare market because it's so profitable. And then, of course, you have quite another market which is totally health damaging. So if you look at the health economy, one of the things that's always discussed is, do we also include the health damaging economy in the health economy in terms of, which then raises questions of investment and divestment in certain kinds of economy. So, of course, at the back of that is always the question, which kind of economic model do you work with, and how do you see your society? Anya spoke about welfare states. There's a very interesting discussion, and I think Finland is going to bring that to the discussion of the European Union, to say we actually don't speak about welfare states anymore. We need to actually look at how we organize a well-being society, and that well-being society would also then work to different economic rules. And the healthcare sector in the widest sense, or the health sector, would play a very significant role within that. And that then, of course, also has consequences. For me, it's always intriguing, if you go into the political sphere and people sort of the ministries are handed out, and it's considered that the health ministry is one of the weaker ministries and one of the less important ministries. If you actually look at the relevance of the health economy for any country, it should actually be right up there next to the finance minister, and he should be much more aware of it. So the political choices that come with this, and I mean, while I fully agree, yes, we have to look at all these local things, unless you have the political will in a country, like, for very different reasons we had with Bismarck and Beveridge and other such introductions of systems, that you are going to establish a system that ensures access, and particularly that is redistributive, and that makes sure that the weakest in society have access. And that's been done in different ways, like the 30 baht in Thailand, etc. But I think all our discussions of how we deliver primary health care and universal health coverage, if digitally or otherwise or whatever, we need to think about what are the adequate financing systems guaranteed through political decisions within governments and parliaments that will ensure that access, even of the weakest, and will ensure the quality. Because the way it's organized now, there are enormous profits in this health economy that do not ensure access and that do not ensure the quality. And that is something that very, very significantly needs to be addressed. And let me add one thing. It's not just, some companies out there that are making the profits. It's also a very significant part of private providers who are paid through public money, who are actually in the way of reform of our health systems, particularly in the developed countries. So, we have had in my country, in Germany, the opposition of the medical profession to certain innovations in the health system, the opposition to sharing authority with nurses and midwives, the opposition to financing primary health care better than specialist medicine is absolutely extraordinary and very, very difficult to handle politically. So I think also those kind of things need to be part of the equation where really this political debate is happening, and the extent to which citizens and patients and civil society can participate in that political debate. The global new economic order and primary healthcare declaration, of course, wasn't created in WHO. It was an outcome of the Brandt Commission, where at a certain point in time, the international community, like with the SDGs, thought we need to be talking about a new global economic order. And so I think it's also that interface of how, through the climate crises and many of these other developments, that larger debate on how we actually want to share the resources in our world then reflects on health and how health can actually contribute to that more just society.
Well, thank you.
Okay, so maybe I can go next because I'm closer to the mic here. First, I would like to answer your question very quickly and then maybe get back to the conversation up there. It's about the fact that, and today we were speaking about this, and Peter Salama was going through this, about the realities on the ground, that when you go to DR Congo and you go to Northern Kivu, you know, this may be important, this digital health, but this digital health is probably more important. Because you go to facilities and you don't have find water, you don't find electricity. So the journey to having technology change the paradigm, especially for those left behind, is far. And actually in some places we may even look at digital as an enabler, but in many places it could be an excluding device because, you know, when you look at it uniformly. But I hear where you're going, but we just need to be cautious that those left behind still need the digital health of the digits and the eye-to-eye conversations and putting the places where they need to be. Now, let me talk about the question that you referred to, Agnes, about UHC in Africa, and I know she'll give a more informed and evidence-based answer. When I look at the countries that are towards achieving universal health coverage, and they are very consistent about it, Ethiopia is one of them, moving towards in a very consistent manner. Rwanda is another, moving towards a very consistent manner. Now, my kind of observation, and maybe this is the next book I'll ask Ilona and Jeff to write, is that countries that have more state control seem to be making progress than countries that are more free market. And therefore, a book on politics, constitution, governance, and health would be an important book to look at. Because in countries that, like Kenya, where actually it's a free market with a very open constitution, every change you try to make goes to court. And I think Ilona has referred to this. Private sector says we can't do that because we'll lose money. And they go to court. And the government is actually in capture. They cannot make progress. But where we have state control, Rwanda says this is the way we are going to go, and that's the way you go. And therefore you see 90% of the people have access to, it may not be optimal, but it is getting somewhere. So this is the whole conversation around whether social and political rights or social and civil rights are more important than economic and political rights, which is a debate all the way from the Cold War, and I don't want to get into that. But that really is an area that we need to look at. So I would want to say, the other thing I want to say very quickly is that the danger we have in universal health coverage is to look at universal and convert universal to mean uniformity. I think it's really clear that universality is stating we need to first go to those left behind and bring them up to the level of the others who are already there, which is about equity. Now, governments might misunderstand universalism to mean 100% of the people equally sharing what's available. If you look at the $40 I talked about, if you actually focus on those left behind and say that those who already are able to absorb catastrophic health expenditure, though not the right thing to do, should be the ones to come next. But the ones who actually are getting impoverished, who are those who are on the border of poverty, should be the ones the government focus on first. So I would say post-declaration, governments need to disaggregate, look at those left behind, focus on those, and focus specifically on sexual health and productive health, because then you address the issue of population development that Agnes was talking about. Because we don't capture that, we continue having 40% of our labor ward admissions being girls under 18, and therefore the teenage pregnancy issue. So sexual health and family planning needs to be critical to the journey towards universal health coverage.
So, Agnes and Fumi, do you have any comments to add?
Yeah, let me try to give three succinct points. I think on what just Ilona and Githinji said on the history of welfare state is when Ilona goes back to the original idea of UHC comes back to the 19th century, Bismarck, Germany. And you see that at that time, UHC was not about health outcomes. The health technologies available in the 19th century were very, very limited, right? There were no antibiotics. The germ theory was not even out there. There was no surgery. There was no vaccines. So the fundamentals of UHC start with the social contract and with politics. It's about redistribution, and the fundamentals, and I'm not going to go there, I'm not being German, but the fundamentals was actually the issue of social cohesion and responding to pressure from the bottom that were calling for more political rights. And the response was to provide a new social contract. And in many ways, it's still there, but it's still there with a whole different technological environment and with many more technology that actually make the difference in the life of people. So when we discuss UHC today, there is a tendency to mix the issue of the social contract and the issue of modern governments providing services to their citizens and providing welfare and equity, and the mix with achieving health outcomes. Because in fact, when you looked at the outcome story, it's extremely driven by economic growth, right? Much more than by government intervention, but government intervention matters too. And when you mentioned the new, I think your question about the new economic order, and I come back to this fact that the welfare state is a very modern, the modern welfare state is a very new thing and still evolving. And in fact, there is a lot of premises that show that probably the way modern states are financed and the way they operate will be very different 20, 30 years from now. So yes, we've learned that really taxation is a great thing. But you see, the modern states, it started just with taxing what you could. It was like the excise tax. You could tax tobacco. This goes back to Adam Smith and alcohol. You could tax trade. But now most countries fund the public services through income tax and sales tax. But there's nothing that says that it's not given by God, right? It's nothing that says that we will always have income tax and sales tax. And actually, there's a growing literature that says that probably something like financial transaction tax. Let me be a bit, controversial here. That the financial transaction tax, quite a small one, could actually could generate public revenue at the current level, just that one. And here we're talking only about the financial transaction tax that could actually replace all the other taxation. We're talking increasingly about increasing the level of the tobacco tax, alcohol tax. We're talking about sweetened beverages tax, sugar tax. What we're discovering at this, either at what says the end of the long 20th century, if we think we're still at the tail of the 20th century, at the emergence of the 21st century, we're talking about an acute awareness of the power of fiscal policies. And we knew fiscal policies were great things to raise money for a collective pot that we could spend. That we've known. But what we increasingly get better at is understanding that fiscal policies are a market signal. So wherever, if I take the example of a tobacco tax, the original excise tax was just to raise money. It was just for the government to have money to play with. Now we know more and more that the tobacco tax is not that much as much as giving a signal to the market, consume less. And that goes with all the fiscal policies. So we see that we're going to have increasingly intelligent and agile and smart fiscal policies. And it's not going to be only on the spending side, but it's also going to be on the revenue side. And that's what I think is when you talk about universal income, when we talk about developing budgets whose objective is well-being, we're talking about a whole new world there. Right? When we talk about measuring the impact of the health sector as patient-recorded experience, as patient-recorded outcome, we're moving to a whole other world. And that's the government we need to invent together, because governments are shaped by their citizens. So we are the ones, we are the principals. We have to change it. So I'm happy when I hear a junior doctor from the NHS, because, for me, I'm getting close to the time where I'm just going to retire and go to the beach. But you will have to take that battle on. So that's really it's the modern government is still to be invented. It's not like we're bound to the model we have today, and let alone bound to the model that was designed by the Bismarck in 19th century Germany. The second point is on the wellness industry. I cannot agree more. That's what actually gets us from the 7.5 trillion to the 10. If you start adding the wellness industry, it's not counted in the health expenditures, yet it contributes immensely to health. But I think so the key point is to understand that when we say 7.5 trillion in health, we're talking about a narrow set of well-defined health services delivered by the health sector. So that's why, as an economist, I'm always concerned, about, for example, when we say, well, we need to reach 5% of GDP for health. That's not what we measure. We measure the percentage of GDP that go to health services. So the question is, if we reach 5% of GDP going to health services, and at the same time you cut the money that goes to water, or you cut the money that goes to female education, then it may not be a good thing for health. So we always need to be aware that what we would measure. We don't measure the spending on health, and Ilona said it very rightly. We measure the spending on health services, and that's really, really very different. And that brings me to the question on Africa, and I will disagree with Githinji. I mean, we love disagreeing, and I think he's very elegant because he's Kenyan, so he criticizes his own country. But actually, if you look at all the health indicators, they're better in Kenya. So Kenya is doing actually quite well, and one of the reasons may not be in the health services as much as education. Kenya has one of the best education outcomes in Africa. And when you ask, are there countries doing better than others? Sure, I won't give examples and names of countries. But yes, there are countries that are doing better in Africa. But I think there is just an equation that is an extremely difficult equation for many low-income countries, for most low-income countries in Africa, and even some middle-income countries, which is the demographic equation, which is still very, very rapid economic growth, very high fertility in West and Central Africa. The economic development that doesn't create jobs. I mean, there is no industrialization. Actually, the percentage of manufacturing job has declined in Africa. So the model of growth based on industry is still looking for it. So there's question about what is the model of growth. It's been really commodities driven, and it's raw exports driven. So you have this issue of a very rapid population growth with a less rapid economic growth, and then you have, unfortunately, in the equation, the climate change parameter, which was also mentioned, which is hitting Africa very much with droughts, with extreme events recently in Mozambique. So it's not to say that on the health side that African countries don't do well. Actually, there's been a lot of progress on the health side. What I'm just saying is there is not the same optimism on the spending, on the expenditure side as there is in other regions. But there are progress, and most of it, I would say, is linked to adoption of new technologies. You know, if you put antibiotics and vaccines and bed nets in those countries, yes, it makes a difference. And we see child mortality has fallen in a very dramatic way in most African countries, and it's an incredible success story. So there are successes, and they're very, very, very sizable. So there is a sense of optimism, I think, on health indicators. But I will conclude with one metrics, and this is where I would say that also the point that Githinji made is not really supported by data, is that when you look at the public spending on health, you see a very, very strong correlation between public spending and financial protection. So basically, the premise of Bismarck and Beveridge, that by providing public subsidy to health, you provide social protection, you actually get again and again the proof that it is actually happening. The more countries spend public money on health, the more you actually reduce financial hardship, right? But when you look at service coverage, you actually have a difficulty finding that. Actually, most primary health care is funded by households, and most of utilization of health services is driven by income. You have difficulties finding a role of the state. And the recent work that's been done on looking at whether democracy or more authoritarian approach are better doesn't find any really convincing factor. Unfortunately, and as an economist, you will say, of course she's going to say that. When it comes to utilization of health services at the end, it's a lot about income. And the redistribution comes mostly on financial protection. And that's why it's a big opening for us for action. Primary health care currently is funded by households. So how do we get governments, that's about that shift about how governments can now shift their expenditures towards primary health care. That, in my view, is the question of the 21st century, is the question of the SDGs.
That's an important point. Fumi, you get the last word. So.
Oh, wow, that's a lot of pressure. But I think, so, I mean, I'm an economist-ish by training, so I'm a pragmatist. So I really believe, I've worked in a number of different country contexts, regardless of the political infrastructure, there's a way to make the business case, if I may use that word, for health. So I think, again, it really comes to how do we locally come up with the right structure, the right arguments to get to where we need. And we can argue about whether private for profit is evil or not, but we're here. So how do you want to use us to achieve our common objectives? And so I think there's a way in which we can contribute not only to health, but also, to productivity and economic development goals. So I think it really needs a national conversation based on the different values and different political realities that exist in order to achieve our common objective, which is universal health coverage and health for all, and really in our own specific ways, figuring out a way to leave no one behind. So my personal experience from working in the US government, so again, this is my personal opinion, but if you look at what quote unquote Obamacare tried to do, it was working within the system, how do we increase the subsidies to extend coverage, whether through the Medicaid program or whether through subsidies in the private insurance market. So there are ways and means to achieve the health outcomes and the financial protection goals that we're looking for, but we have to be creative and we have to work together in order to, in a short term, achieve these objectives. Now, long term, the next generation can maybe work on the broader, framework for governance, but at least in the short term, there's a lot we can do together if we collaborate. So I think it is daunting, but still achievable to move in the right direction. But I think rather than pushing against a brick wall, moving with the flow in some sense, at least in the short term, might get us a little bit closer to where we need to go.
Thank you. So I'd like to just ask Ilona to offer us a few concluding remarks.
Concluding remarks. Well, I feel very, very strongly that we need to change the narrative. And I think discussing the health economy can help us change that narrative. That is, how do we ensure that people have access to health and to health care? And I believe in the UHC debate, we have still not clarified that we're on about both. And then we have to be much clearer about our economic arguments. And some of you know that I have argued that just like the Director General has a chief scientist, he should have a chief economist. Maybe he already has a chief economist. And since all of the other ones I know of are female, this one is female too. But I do think the conversation needs to change because of the very, very significant overall economic impact and economic implications of a health system in the widest sense of the word. And unless we get that straight, I don't think a lot of our arguments, you know, a sort of investment case here, an investment case over there, is really going to take us forward. I don't agree with Fumi, because for 30 years, we have tried to be pragmatic. Whereas, you know, in brackets, it's news to me that economists are pragmatic. I often have a different experience on that. And thank God they're not all pragmatic, because, you know, if you do listen to some of the recent Nobel Prize winners who are economists, I think it's not pragmatism, but to some extent also vision for a future economy and for a juster society that has actually given them that prize. And Amartya Sen, I think, is one of those that we would be thinking of then. So I do think what we have to face is, after 30 years of going after problem, sometimes with fantastic success, population group after population group, unless we put our force together and argue for systems of financing and systems of providing care and health, we are going to sit here in 10 years again and say we have not achieved it. And as I've said on other occasions, you know, now we say no UHC without NCDs, no UHC without tuberculosis, no UHC without diagnostics, no UHC without everything. I think, you know, it's actually the other way around. If we want to get all our agendas addressed, we need a system of finance and of delivery within which they can be addressed, and where particularly the most vulnerable will have access. And if we can change the narrative along those lines and actually show how important health is in economic terms as well as in terms of human capital, of a more just society, and of a new kind of well-being society, then I think we will have made a better argument. So we will look at the next book.
Thank you.
And maybe you'll contribute, Githinji. Okay.
Good. Well, thanks very much, Ilona. That was a powerful and appropriate note on which to conclude. Please pick up a copy of The Road to Universal Health Coverage as you leave. There's more on these issues in the book. And I'm just pleased to see that we've provoked such an interesting and rich discussion. All that's left for me to do is to thank Githinji, Ilona, Agnes, and Fumi for really taking us through such an interesting conversation. So thanks so much.